I need to stop sharing. Good morning to Pediatric Grand Rounds. It's my pleasure to introduce this morning's Grand Round speaker, Dr. Brandon Hadfield, who is a third-year neonatal perinatal fellow at our institution at the University of Texas Health Science Center in San Antonio. He received his MD degree from University of Kentucky in 2013. He completed his pediatric residency from Naval Medical Center in San Diego in 2016. And from 2016 till he joined our fellowship here in 2020, he served as the solo staff pediatrician and pediatric consultant at Naval Hospital in Rota, Spain. While in Spain, he served as a medical director of newborn nursery and immunization medical officer. He also served as a department head, early development and intervention services from 2016 to 2018, and also as a chief medical informatics officer from 2018 to 2020 at the U.S. Naval Hospital in Rota, Spain. His clinical interests include neonatal resuscitation and simulation, as well as neonatal global health. So Dr. Hadfield, thank you very much for accepting our invitation. And he's going to discuss today hyperbilirubinemia, a review of the AAP's 2022 guidelines. So the floor is yours, Brandon. You're muted.
Good morning, all. Can you hear me now, Dr. Kamai? Good?
Yeah, we can hear you and see you well. Thank you.
Good morning. I'm going to talk about hyperbilirubinemia. In the NICU, sometimes I feel like we are somewhat siloed from the rest of pediatrics, but bilirubin and hyperbilirubinemia is definitely one of the intersections between neonatology and general pediatrics. So the objectives for today's talk are to review the 2022 AAP hyperbilirubinemia clinical practice guideline. We're going to discuss some of the evidence surrounding these recommendations, review and understand the best practices regarding prevention of hyperbilirubinemia, understand appropriate assessment and workup of hyperbilirubinemia, and review current treatment recommendations, escalation of care, and exchange transfusions. If any of you have read this guideline, it is a very thick guideline, and so I will not have a ton of time to deviate a ton from the guideline, but I will kind of go through it in a very systematic way. This is the guideline, clinical practice guideline revision, management of hyperbilirubinemia in the newborn infant, 35 or more weeks of gestation. And the most common question as I talk to different people and residents about this I get is Bhutani still involved? And Dr. Vinod Bhutani is now emeritus at Stanford, was involved and was on the paper, is highlighted there. So just a little bit of background for the guideline. The previous guideline was in 2004 with the 2009 commentary and modifications. Since that time, the authors state that the, quote, incidence of hazardous hyperbilirubinemia, which is a bili greater than 30, has decreased, and they attribute that to the adoption of universal pre-discharge bilirubin. And this has been shown in a couple of different papers, the most notable by Kunstevitz in a Kaiser study. It is specifically applicable to the US and may not be applicable to other low middle income countries. They divide their paper, and thus I will divide my talk into three basic categories: prevention, assessment and monitoring, and treatment. There are 25 key action statements from this paper. I will highlight them in this green color so it stands out there every time one of the key action statements. There is a reported evidence for each one, which if you're interested in the evidence, because as I will go through these, sometimes there are some that you may think, and I sometimes think, this doesn't seem to be the best practice. They will talk about the evidence that's expounded in the supplement, which I'm happy to share with anyone who desires. This is just an example of what that supplement looks like. This one's specifically talking about escalation of care, but you see here they go through the benefits, the risk of harm, the benefit harm assessment, and if there is literature, they'll put it in this intentional vagueness, preference strength, and all of those things. So now jumping right into it, starting with prevention. Just as a review, because it will come up again, here is the pathway of the red blood cell, which thus becomes our bilirubin pathway. The red blood cells are made in the marrow, and then they go to the reticuloendothelial system, which I did again review to make sure I was saying the right thing as I was talking. The reticuloendothelial system is most commonly defined as phagocytic cells like macrophages. So they start the breakdown process of our nascent hemoglobin, where it is broken down by hemoxygenase to biliverdin, then from biliverdin to bilirubin. this is all in that reticuloendothelium in the blood. And then once it's in the bilirubin stage, it is bound to albumin, that bilirubin albumin complex, which is important, and we'll talk about that a little later. Then goes to the liver, where it is, and we'll talk again specifically, there's a lot that happens in the liver. This is a quite oversimplification, where it becomes conjugated bilirubin and is pushed out into the bile. In the bile, a lot of it is recirculated through enterohepatic circulation. Some of that ends up in the kidney for urine bilinogen. But you'll just see that it is a very complex pathway, and I do not have time to talk about this whole pathway today, again, focusing on the guidelines, but it is important to understand that as a precursor. So I did put a slide in here about physiologic jaundice because it is something that 80% of the newborns will have some degree of jaundice. It occurs, true physiologic jaundice, as defined by Vanderhoff and Martin, occurs from day 1 and rapidly declines to around 1 week. The average cord bili is about 1.5, and according to this one reference, it peaks on day of life to around 5.5. That's just for our physiologic jaundice. There is a plethora of physiologic reasons for neonatal jaundice. This here you see over here is the amount of jaundice right as it peaks, and where that jaundice levels come. So as we get further, I'm sorry, this is not the peak of the jaundice. This is the level of the UDP glucuronidyltransferase, which is low, which causes jaundice levels to be a little bit higher in babies. So it is very low levels, especially in our preterm babies. Even by term, the level is here, and then your adult is much higher, 1,000. So this is a logarithmic scale. Other reasons that we have jaundice in the neonatal period is because of increased hematocrit. There's an increased RBC volume per body weight. The red blood cells don't live as long. There is a 6 times bilirubin load presented to the liver with the decreased UDP glucuronidyltransferase. Moving on now, this is something very commonly discussed, breastfeeding and breastfeeding support. Breastfeeding in jaundice, also called suboptimal intake hyperbilirubinemia, 3 to 5 days after birth, excess weight loss, decreased stools, and there's an increase in enterohepatic circulation because you're not stooling, versus your breast milk jaundice, prolonged unconjugated hyperbili, which can last up to 3 months. It's associated with a variant UGT1A1 promoter. Interestingly, in this study, they looked and found out what were in breastfed infants, what were the levels, the average levels. So the TCB is greater than 5 and 34% of these at day of life 28. It's greater than 10 and as almost 10% of them, and it's greater than 12.9 and 1%. So you still will have some jaundice at 28 days out. Continuing, they do take a pause in this guideline to talk about breastfeeding. Quote, clinicians should promote breastfeeding support for all mother and feeding within the first hour of life. I think as a resident, sometimes the thought was that the breastfeeding and jaundice were not compatible and we should go straight to formula. That is definitely not what the recommendation suggested. Recommending feeding at least 8 times in 24 hours to ensure, quote, sucking adequacy. And then breastfed infants who are adequately hydrated should not routinely receive supplementation with infant formula. It does take a pause to talk about something which is very important, G6PD, that comes up again and again. It is one of the most important causes of hazardous hyperbilirubinemia leading to kernicterus, and we'll come back to this a little later in another one of my slides. So very commonly we have jaundice, not very commonly, but when we do have jaundice before 24 hours, it is the most common cause that gets identified of causing jaundice before 24 hours. However, in a vast majority of places, we don't get a cause. So while it is the most common cause, it is not commonly identified for that jaundice in the first 24 hours. It's an X-linked recessive enzymopathy. There's genetic ancestry from sub-Saharan Africa, the Middle East, Mediterranean, Southeast Asia, and the Arabian Peninsula. And as many as 13% of African-American males and 4% of African-American females, because that X-linked recessive trait, have G6PD, which means there's more than 400 million worldwide. You should consider this when there is severe hyperbilirubinemia or atypical hyperbilirubinemia, for example, elevated bilirubin in a formula-fed baby or a very late onset jaundice. However, one of the hard things about this is there's a high incidence of a false negative test. So if you do have a negative test, you're supposed to repeat it 3 months after the hemolytic event, which would be that severe jaundice, or if the baby does receive an exchange transfusion, repeat it 3 months later. So this just is a little pause to one of my other side interests. This in December, I had the opportunity to go to Nigeria, and this was a little bit eye-opening to me. I did talk with Tina Schlechter, who was a previous speaker here, but this is some of the things we see just as a note here. This is a baby under phototherapy lights. The other thing that is remarkable, and couple things that are remarkable, to increase the ability of phototherapy, they put the tin foil around here to get some reflective properties of the phototherapy. And then the other thing that you'll see here is this baby has a mosquito net because they didn't have air conditioning in the hospital, and it was quite warm, so they would open the windows, and so all the babies' beds had mosquito nets over them to protect from malaria. Another comment on that, and this did come up a little bit in the guideline, but more, there's a few papers written about racism in hyperbilirubinemia, which was a new concept to me, but I thought it was important just to put a slide in about this. So interestingly, the 2004 update included Black, East Asian race as risk factors. In the 2022 race, it was completely removed. Race is often patient subjective, and what should be targeted is the geographic ancestry and disease markers within the diverse genomes. Meaning that if you ask someone what their race is, they may say that they're East Asian, but it's very patient subjective, and what we really want to know is their geographic ancestry and the markers. The risk factor is the family history or genetic ancestry suggestive of inherited red blood cell disorders, including G6PD. And that's a quote straight from the guideline. The East African risk factor, as they looked back, didn't actually decrease kernicterus in that population, but did increase treatment of infants claiming East Asian race. So these infants were, by some people's definition, overly treated because of this. And the Black race, it's the 2004 guideline, was noted as protective, but because of some other socioeconomic factors, there was actually some probably increased incidence of kernicterus in the Black race. And a quote from one of the articles that was particularly poignant: "It is not a patient's race that is associated with their risk for kernicterus. Rather, it is a far more complex interplay of genetics, ancestry, and societal factors, including systemic racism, access to healthcare, choice of feeding method, and likely many other latent and unknown factors." Meaning that we can't say that all the race is at risk, but different factors make different risks. The guideline kind of starts out with our first key action statement talking about isoimmune hemolytic disease. Here you see the green marker, which you will see again and again throughout this talk. If maternal antibody screening is positive or unknown, an infant should have a DAT and infant blood type performed ASAP, meaning that if you don't know what it is, you should be checking an ASP if mom was not screened. The ACOG does suggest that all women need an ABO or RH test, but as we all know, not all women get appropriate or full prenatal care. If the DAT, if the mother is DAT positive with the RhoGAM antibodies, you can presume them a negative if your lab is able to tell you that you have RhoGAM antibodies. If mom's blood type is O positive and antibody negative, there is, quote, an option to test the cord blood for infant blood type and or DAT positive. However, determining that blood type is not necessary if bilirubin surveillance follows the clinical practice guidelines. It is common practice of many hospitals to test all the O's or all the negatives, but this guideline suggests that if we're following all the guidelines, we do not need that if we know that mom is DAT negative. This is our first figure 1 that just kind of talks about what to do if you are DAT positive. This is a very aggressive recommendation, but just so if you're DAT positive and it is a true DAT positive, the official recommendation is to measure the TCB, the transcutaneous or serum bili. TCB is transcutaneous, immediately, then every 4 hours times 2, then every 12 hours times 3. Again, a quite aggressive recommendation. I think it's because of the fear of DAT. I am going to try and keep my own biases out of it. Again, a pretty aggressive recommendation for that. So that's a lot of labs that would be required for all of our DAT positive babies. So moving now to the assessment and monitoring portion. What are the risk factors for significant hyperbili? It's important to know that these risk factors are not the same as neurotoxicity risk factors, which I'll get to later, but the risk factors for having significant hyperbili: lower gestational age, and we'll talk about this a little, but it increases with each week. So previously there had been specifics, 37 weeks and below, 37 to 35 and above 37, but each week is different. Jaundice in the first 24 hours, pre-discharge bili near the phototherapy threshold. hemolysis, known or suspected, phototherapy before discharge, parent or sibling requiring phototherapy, family history of RBC disorders, exclusive breastfeeding with suboptimal intake, scalp hematoma or bruising, Down syndrome, and a macroscopic infant of a diabetic mother. Moving now to another interesting thing which I have heard of and was interested when I heard that they decided to make commentary on this, visual estimation and the total serum bili. So this is interestingly the Kramer method developed in 1969 of determining what a bilirubin is. So if the thought is if they're jaundice up on the face, then their bili would be around 5, and as that jaundice level spreads down to the feet, the palms or soles, then they would be greater than 15. So what is the evidence or lack thereof? The first important thing is key action statement number 3. Total serum bili is the definitive test to guide phototherapy and escalation. So they recommend if you're going to start phototherapy or escalate care that you have a serum bili. Visual estimation, or what they call cephalocaudal progression, says that there is in some studies there suggests a generally high statistical correlation. However, there is as much as 13 to 15 milligram per deciliter difference, meaning that bili could be 3 and you would call it 18 or vice versa. So it is not, and as this scatter plot demonstrates, a complete scatter all over the place of this is the serum bili and this is the estimated bili, so they do not correlate. But interestingly, they do comment that all of the infants should be visually assessed every 12 hours from delivery to discharge. And I think this is important for our nurses as we talk about bilirubin, that if a baby, especially in the first 24 hours, is looking visibly jaundiced, then we just take action. The other thing they do seed is that visual estimation is routinely used in term outpatients greater than 3 days. And all infants should have at least one bilirubin between 24 and 48 hours or prior to discharge. I didn't mention, but I think it is important that if there is no visible jaundice, it is pretty reliable that the bili is less than 12. So transcutaneous bili. This is an interesting tool. I know we do not have them here, but it is I did use them in Spain when I was in Spain, and it is a helpful tool. So key action statement number 6, the total serum bili should, and I should pause here, there's 2 different devices. One is the Philips and one is the Draeger. These are the ones that are most studied. There's actually more than that, but these are the ones that are most studied. What they do is they measure the yellowness of the skin. It's reflected and then uses an algorithm to predict this total serum bili based on objective measurement of the skin color with the reflectiveness and the yellowness in the skin. The key action statement number 6, though, total serum bili should be measured if the TCB exceeds or is within 3 of the phototherapy threshold, or if it's greater than 15. We talked about these 2 devices. Interestingly, it is affected by the skin melanin, and one of the devices overestimates the African American, and another device underestimates. So you just have to know that if you're dealing with a black baby, that it could be over or underestimated by about 1 is what their study suggests. It's an indirect measure of jaundice. It does definitely, and I definitely saw this, decrease in unnecessary blood draws. It was our practice, which is not suggesting this is the necessarily correct practice, but it was our practice to get a TCB on every baby before they went home. And at 24 hours, we did get serum bilis, but that is not necessarily the recommendation. If the TCB remains low, there is no reason to get a serum bili according to the guideline. So monitoring of the bili. Key action statement number 7. The rate of rise can be used to identify higher risk infants. The rate of rise is something that has always been a little bit of an enigma to me. It's something that is often discussed, but I haven't necessarily, I'd heard the number 0.2, but I loved how this one specifically talks about that. So they consider a rapid rate of rise an increase of greater than 0.3 per hour in the first 24 hours, or greater than 0.2 after 24 hours. It suggests hemolysis, and so you should think about hemolysis if the rate of rise is high, and they suggest performing a DAT if you haven't already done so. Another interesting thing which they discuss in the guideline, which I thought was interesting, they would bring it up in the guideline. There is some studies that suggest that N-tidal carbon monoxide can be more helpful than DAT for hemolysis. There's only a few studies about this, but basically carbon monoxide is one of the breakdowns of hemolysis. And so it may be a better predictor, but more to come on this as more studies come out. And key action statement number 8, hospital discharge may be delayed if you do not have follow-up for monitoring that Billy. Now back to our neurotoxicity risk factors. These are our babies, and I borrowed some of these pictures from Tina Schlesser, who was here earlier last year. If their gestational age is less than 38 weeks, I think that I don't like that as a risk factor, really. They did include it, but it's almost like a double risk factor, and I'll speak that a little when we get to the charts later. But while it is a risk factor for neurotoxicity if you're less than 38 weeks, the charts make you pick between neurotoxicity risk factors and no neurotoxicity risk factors. This does not count as one of those neurotoxicity risk factors when you're picking which chart to use. If your albumin is less than 3, if you have isoimmune hemolytic disease, G6PD, or other hemolytic conditions, sepsis, or significant clinical instability in the last 24 hours. Excuse me. Moving now a little bit to a little aside to talk a little bit about albumin and bilirubin. So unbound bilirubin is what is most likely to cross the blood-brain barrier and give us kernicterus, the fear of all of these things. Albumin binds, each molecule of albumin binds at least 2 molecules of bilirubin. There's 1 high affinity site and 1 to 2 lower affinity sites. 1 gram of albumin will bind 7 to 8 milligrams of bilirubin. So 3.5, the normal level of albumin, binds about 29.4 milligrams of bilirubin per 100 mLs at each of the 2 sites. And this is what is interesting as you talk about bilirubin. If you have a bilirubin level of 15 and an albumin of 3, your risk of toxicity is the same with a bilirubin level of 30 and an albumin of 1.5. The other thing that comes up over and over again, especially in some of our testing and as it comes up as we treat some things, there is decreased binding of albumin is caused by obviously low albumin or these competitive drugs. So this is why we do not recommend the sulfa drugs and ceftriaxone in that when they're at risk for hyperbilirubinemia. Also, illness can cause decreased binding of albumin. But there is, as they kind of parse this out a little bit more, albumin levels and binding ability vary a little bit between newborns, so you can't say all newborns are going to bind exactly. It is just a guide. And then this is a chart which comes from the previous guideline, but again is brought up in this guideline, that if you have a bilirubin to albumin ratio that is greater than 8 or greater than 6.8 and like these smallers, then you should that can be a risk, and you should consider doing a double volume exchange transfusion. So moving now to direct hyperbilirubinemia. Remember that conjugation is made by glucuronic acid in liver to make the bilirubin water soluble. As an aside, direct hyperbilirubin and indirect are not exactly the same thing. The direct and some indirect bilirubin react with chemical reagents to measure the direct bilirubin. So because of this, the conjugated bilirubin is better than direct. However, the direct is most commonly used as a surrogate and much easier to test. And for almost all practical purposes, the direct does serve as a good surrogate for conjugated bilirubin. So previously there had been some questions, what is direct hyperbilirubinemia? And I wish that Teb were here, our beloved resident who did all of his studies on the direct hyperbilirubinemia. There is a joint North American and European hepatology societies. They define it as greater than 1. If it is elevated, they suggest repeating in a few days to 2 weeks. And there's currently our policy here that we check it at 24 hours per the guideline that Teb and Dr. Shaw helped to establish as a model after the Baylor guideline. The direct bilirubin greater than 20% is no longer needed for a diagnosis of cholestasis per these guidelines. If the direct bilirubin is greater than 50% of the total serum bilirubin, they recommend consultation with a knowledgeable specialist, which they defined as a pediatric gastroenterologist or a neonatologist. And then key action statement number 9, breastfed jaundiced. Breastfed infants who are jaundiced at 3 to 4 weeks or formula fed at 2 weeks should have a D-Bili and T-Bili to rule out pathologic causes of cholestasis. And I will mention something that came to us in residency. We had a baby that we had received. The baby was in Japan in a military base and was seen by the pediatrician at 2 weeks. The pediatrician's note wrote, jaundice, slightly jaundice, likely breast milk jaundice, which is true based on statistics. And then but the jaundice level was not checked, and the baby was sent home. The baby showed up at 2 months in fulminant liver failure with biliary atresia. So just remembering that if you have a persistent jaundice level, you should definitely consider getting a direct bili to rule out those causes of pathologic jaundice. So, and this is why we do all we do with bilirubin is kernicterus. So kernicterus does occur. This is the bilirubin toxicity in 0.4 to 2 per 100,000 in our upper income countries. They do not know the specific level, and they've tried to say, is there a specific level? And it is variable. So there's no specific level at which it occurs, but it is if kernicterus is a permanently disabling neurologic condition characterized by core athetoid cerebral palsy, upward gaze paresis, enamel dysplasia, sensorineural hearing loss, or auditory neuropathy, dysynchrony spectrum disorder, and characteristic findings on the MRI, which we'll get to. So you see here the pathologic specimens of the yellow staining, especially the basal ganglia. These are our MRI findings. These high intensity markings you see here, those are noted in the bilateral globi pallidi. So I did pull this study, which was interesting as it talked about this kernicterus. It was a big study out of Kaiser, mostly in California, with greater than 500,000 infants. The total so they looked at 500,000 and found that the bili got greater than 30 in 47, so 8.6 per 1,000. They did comment that this number did decrease after the implementation of the 2.4 guidelines, so it was like 11 before and decreased down to 4 afterwards per 1,000. But this is the number. So these are the 47, and I know this is a little bit small, but I think the important things to think. So all of these were above 30, and this is the highest one was 50, and this is their age. But the only ones that had long-term neurotoxicity are the ones that are not circles. So there's right here. So there's very few, only 4 of them with this neurotoxicity. And interestingly, all 4 of these were at least 15 above the exchange transfusion threshold at the time. That's the older guidelines, but they were at least 15. So meaning the risk of neurotoxicity, we don't know what it is, but it is very high. So there was plenty of these right here of this cohort of 500,000 that were in the 30 to 35 range. And I'm not suggesting that we should not follow these guidelines, but just know that the risk it's a high morbidity, but low incidence disease, like kernicterus. This one here that was at a lower in the 32 range, this one was a baby that had problems because they had seizures, but they were much older. And the seizures weren't definitively linked to the hyperbilirubinemia. So it's interesting, this goes down to kind of breakdown, which I thought was also interesting. This is the 47 infants. The most common cause was 21% of them had G6PD. Actually, the most common, they didn't find anything. And these are the ones that had the long-term neurodevelopmental outcomes, and these are their levels. So all of them, except for one, were under 37 weeks, and then their levels were anywhere from 38 to 50. So moving now to the treatment of hyperbilirubinemia. And it looks like I'm right where I need to be on time, so good. So this is a wonderful picture that comes to us from New England Journal of Medicine, which did a great review back in 2008 on phototherapy and how it works. It's a narrow spectrum LED blue light with between 460 to 490 nanometers is the optimal range you see right there. Interestingly, in this article, they quoted that there was a older study back from the early 80s where they withheld phototherapy as they were trying to figure out if it worked. In that specific study, 21% of the infants that didn't get phototherapy were going to need an exchange transfusion. I don't pretend to say that study would be repeated today, but it is important to know that phototherapy does make a difference according to that very, very old study. Porphyria, or family history, is a contraindication to phototherapy. It is one of the very few contraindications. So porphyria is a blistering photosensitivity. And so on the boards for all of the residents that are listening in, on the boards, it'll be a baby that gets phototherapy, gets exposed to sunlight, and then has a blistering rash. There is, and this is going to come up, I know this is very controversial, we'll talk about it again on the next slide, but there is, quote, and this is the guidelines, some evidence that phototherapy can lead to small increases in childhood epilepsy. When I read this, I was very almost enraged, and then as I looked at the evidence, I was not nearly as impressed. But here it is, and so this is, as you look at these supplements, here it is, this is key action statements 10, which recommends phototherapy. And I think this is important though, phototherapy may lead to separation of the mother-baby, maternal anxiety, and reduced breastfeeding. Phototherapy can lead to oxidative stress and DNA damage, although these risks appear to be lower with LED. 2 observational studies found a small increased risk of epilepsy in males treated with phototherapy. If the findings are causal, which again, that's a very big question, for approximately each 100 to 250 males treated with phototherapy, 1 will be diagnosed with epilepsy by 10 years of age. Hospitalization for phototherapy can increase costs and prolonged hospital stay, or the need for readmission. And then the benefit to harm ratio, the benefits are believed to exceed potential harms at the thresholds which they talk about. And I like this statement, even at the treatment thresholds in this guideline, the number needed to treat to prevent 1 infant from receiving an exchange transfusion may be in the hundreds or thousands, and the number needed to prevent 1 case of kernicterus is considerably higher. So it's just an important thing to think about, and I think that as I read this, I am not extremely worried about phototherapy causing seizures. It will continue to be studies, but it does make me think about sometimes when we say, let's just start the phototherapy because we're getting close. There is sometimes when that is appropriate, but I think that especially these findings up here, the maternal anxiety, separation, longer hospital stays, those kind of things are just things to think about. Continuing a little bit more about phototherapy, I think that this is an important tool, which isn't all. This is for measuring radiance, and we'll get to that in just a second. But you can, per the guidelines, start at lower levels. And so I was just talking about based on the rate of rise and discharge consideration, but should consider that risk of treatment. And I think the risk that you should be considering is not necessarily the epilepsy, its effects on breastfeeding. Irradiance should be verified. So this is how you measure your irradiance. You measure at the center of the light source. The irradiance should be greater than 30 microwatts per centimeter squared. So this one here you would see is 35. And again, there is no evidence that phototherapy prevents or improves kernicterus, and that's what the guidelines suggest, although that is a little stronger than what I would like to say, but it is important to remember that those levels are very high where kernicterus would actually occur. And because of this, though, the evidence supports increasing those transfusion thresholds to be a little bit higher than what we normally would do. The other interesting thing, as you may or may not remember, when Tina came to talk to us, Tina Schlusser from Minnesota, she talked to us about phototherapy in Africa and did find that as they tested those phototherapy banks, they were not getting the irradiance that they needed, which may have caused some of their problems in treating phototherapy. But interestingly, she said she came back and 20 to 30% of her nursery were not able to get the levels, they weren't getting the right intensity. And so it is important to think about, especially in a baby that's not getting better, to test that. I know in the NICU that we test this every shift, but it should be something that should be tested. There was this New England Journal of Medicine Kaiser study where they looked for the Hyperbili of in 2006 with this bilirubin between 25 and 30. So not quite as high, but again, above that threshold. Only 5% of these kids got an exchange transfusion. There was no cases of kernicterus and no adverse long-term outcomes. So in that range, at this time in the United States, there wasn't any long-term outcomes. So a side note, sunlight is phototherapy. Direct exposure to sunlight can and has been shown to decrease the total serum bili. However, as a pediatrician, I did have a dad who was a nurse who didn't want his kid to get admitted, so he did take his baby out in the sun to try and decrease the phototherapy. This kid was having some breast milk jaundice, and interestingly, the dad brought the baby in who looked just like this. So the baby did get pretty significant sunburn, and the dad felt horrible, but it did decrease the bili of his child. It is practically challenging and it's difficult to avoid the sunburn, both inside and outside. Filtered sunlight has been used safely in resource-constrained settings, but again, these AAP guidelines are not for lower middle income countries, so they do not recommend sunlight as a treatment. This is the paper by Tina about the filtered sunlight. You see how they did it almost like a greenhouse outside of their hospital to treat the phototherapy. And they did show some effect, especially if you start treating early. So we'll move straight into our phototherapy thresholds. This is the new curve. As you see, the curve is a little different than the older curve. There is a different line for every week. There is two tables, this one without neurotoxicity risk factors and the next one with neurotoxicity risk factors. You see increasing thresholds as the gestational weeks progress. So at 40 weeks, your risk is lower, so you will start phototherapy later. And this is the toxicity risk factors. And the question that I had as I came up as I was looking at these guidelines is, what's the difference? What changed or what didn't change? So I made this table here, which is hopefully a little bit helpful. So you can see the 2004 guidelines are over here and the 2022 guidelines are over here. You see that the phototherapy threshold did go up by about 2 in most of these. You will see that 37 and 35 weeks are the same in the 2004 guidelines, because if you remember that they were the same, the threshold was the same in both of those. But you see that there is a little bit of a bump both at 24 and at 96 hours. 96 hours is kind of where it levels off, so that's why I picked that time frame. Some footnotes to these thresholds. They're based on expert opinion rather than strong evidence of when potential benefits exceed potential harms. And you're not supposed to subtract the D-bili, just the total serum bili. And at less than 24 hours, at or above threshold, you should think about evaluating for hemolytic disease. And key action statement number 10, intensive phototherapy is recommended at those levels in figure 2 or figure 3. That intensive is greater than 30 lumens. And then the option, there is an option to begin subthreshold to avoid readmission or rate of rise, depending on as you examine the whole baby and the whole picture. Again, a reminder of the neurotoxicity risk factors. And I do not get any royalties or anything from BiliTool, but the new BiliTool app is wonderful when you're looking at these new guidelines. BiliTool.org, you can do it on the computer or on your phone. You put in the bili and it will tell you when to, if you're using transcutaneous, when to confirm, when you start phototherapy, escalation of care, and exchange transfusion. It also talks very specifically about when to follow up, which we'll get to in a little bit. So home phototherapy was discussed in this article, and so I thought I would again briefly touch on it. Home phototherapy criteria. Key action statement number 11, home phototherapy is an option for those who meet the following criteria. They have to be greater than 38 weeks and greater than 48 hours old, clinically well with adequate feeding, no neurotoxicity risk factors, no previous phototherapy. The total serum bili has to be no more than 1 above the threshold. The device has to be available without delay. And key action statement 13, you have to be able to do a daily total serum bili measurement if you're on phototherapy. There is an option and the almost suggestion that if you're going to do it, you start a little lower than the threshold, so start at 2 below the threshold. So what do we do now for prolonged hyperbilirubinemia? They define it as greater than 7 days of a bili that's within 2 milligrams per deciliter of phototherapy levels. If it is an elevated bili and it's prolonged, you should consider a D-bili per my story earlier. It is most commonly breast milk jaundice. Other causes include the following. Just as a reminder, Crigler-Najjar and Gilbert syndrome both affect the same enzyme. Gilbert is a missense of the stop codon, so you get a partially functional enzyme, whereas Crigler-Najjar is a complete absence, and Gilbert is the one that occurs more commonly with fasting. So monitoring after phototherapy. So you've been on phototherapy, now when do I have to check it? Key action statement number 12, again, this one is a little bit aggressive. They said that all bili, you should always have a serum bili within 12 hours of starting phototherapy. I think the reason for that is because you don't know your rate of rise, but that timing should be guided by risk factors, age, and the trajectory. The TCB after phototherapy, underestimates the total serum bili. So you can't use a transcutaneous for the first 24 hours after you've been on phototherapy. Key action statement number 14, if they require phototherapy, then they recommend, again, aggressive recommendation to measure the hematocrit as a baseline for every kid requiring phototherapy. And then they also recommend obtaining a DAT if it's O or negative at that point, if you haven't already done so. And then if you have a rapidly increasing, to think about measuring that G6PD. When do we stop phototherapy? Key action statement number 15, Discontinue phototherapy when you're at least 2 below the threshold and at the phototherapy initiation. So if at 24 hours your threshold was 12, then when you get to 10, that's when you would stop, even if that 10 is at 48 hours. Longer if there's risk factors. They do make a comment about the rebound phototherapy. The rebound phototherapy is if you need phototherapy within 72 to 96 hours after you stop phototherapy. Those kids that are at risk for needing phototherapy again a second time are those who got phototherapy within the first 48 hours. Obviously, those with hemolytic disease, if they're late preterm, a higher bili at the time when you stop. So if you're very close to the threshold when you stop, and there's a huge variation in the literature, so anywhere between 4 and 24% of the infants will have rebound phototherapy. This 24 to me is a very large number, and I have not clinically seen that. So when do you follow up after phototherapy? Key action statement 16 says you should repeat your bili based on your risk of rebound. So this is a complex, and if you're thinking about this, and you're going to have to read it again to fully understand. But if you had phototherapy at less than 48 hours, or had DAT positive, or you suspected hemolysis, then you should repeat it somewhere between 6 to 12 hours, and then repeat it the day after, because you just don't want to make a repeat. And these kids that are at high risk, then you want to make sure you don't have a rebound. And I would make an aside comment that if you get phototherapy in the first 48 hours, your risk is probably not the same as a massive rebound as a DAT positive, but we should be following those levels up. If you have phototherapy during your birth hospitalization or twice having phototherapy, you should have bilirubin the day after you get discharged from phototherapy. If you get readmitted for phototherapy, so you go home and you come back and you're over 48 hours, then you need to check, and then your bili comes low, you need to check a bili in 1 to 2 days. And they suggest if you're trying to do it, the best time to do it is 12 hours to get a good rebound. It's kind of a little bit controversial because up here they said 6 to 12 hours, but you want to wait some time after phototherapy because to get a good rebound. This chart is wonderful, and I've talked to a few residents who use it sometimes in the nursery, but it tells you when. And these are kids that did not get phototherapy, but when you need to follow these kids up. And the important thing there is no more risk zones. I know those of us who've been practicing for a little while have used the risk zones to decide when to follow up, but those went away, and this replaces those risk zones. It's basically you take the phototherapy threshold and you minus the bili. So how close are you to that phototherapy threshold to determine when you need to follow up? All of this chart is wonderful. Refer to the chart or refer to this app. So this app, again, will tell you this is your bili, this is when you need to follow up. So this says check it in 1 to 2 days. Again, I did not get any royalties from BiliTool. Moving now to escalation of care. And this is a new thing in this guideline, which I really like this escalation of care discussion. And it kind of, again, it highlights a big intersection between general pediatrics and the NICU. So intensive care should be given for infants. So they define escalation of care as intensive care for infants with elevated or rapidly increasing bili to prevent the need for exchange transfusion and prevent kernicterus. So escalation of care is necessary, key action statement number 17, when you're 2 below the exchange transfusion threshold and you have an increasing bili despite phototherapy. Escalation time, as defined by the article, is from the first bili that is in this range until you get below the escalation threshold. And this time should be in the NICU. So escalation of care infants need IV fluid and emergent intensive phototherapy, to the point where they suggest that if possible, you should do so in transport. So if you have an escalation of care kid that is in the clinic and you're trying to get them, you should do what you can. Obviously, you don't want to delay your transfer to the NICU or to the definitive care, but you should do what you can to give them IV fluid replacement and emergent intensive phototherapy. Escalating care is, quote, a medical emergency. So this algorithm is helpful when it comes to escalation of care. It is key action statements 19 through 23. I'm going to break down a couple of things. So when you first identify an infant that is at risk, you should consult a neonatologist, initiate urgent transfer to the NICU, and as we talked about, intensive phototherapy and PO plus IV hydration, if possible. But again, don't delay. Having been a general pediatrician in the clinic, sometimes getting an IV in these kids could be very difficult. And so again, don't delay, just get them to the center. What are the labs that you're supposed to do on arrival in these kids? they recommend a total serum and direct bili, CBC, albumin, chemistries, type and cross match as in preparation for a possible exchange transfusion. Notify the blood bank. And then when you're in this risk, they recommend measuring that bili every 2 hours to see what direction you're going on. We talked about phototherapy and POIV hydration. And then they talk about IVIG. We'll come back to this, and also looking at the albumin, the bilirubin albumin ratio to determine your options. Then you have those labs. And so interestingly, sometimes if you have those labs, obviously if you ever have acute bilirubin encephalopathy or signs of kernicterus, then you do an exchange transfusion. But if you're still below the level of, if you're still in that range, so this is if you drop below, then you return to regular phototherapy. But if you're still in it, you continue that intensive phototherapy, PO and IV hydration, measuring that total serum bili at least every 2 hours. Couple of other notes, IVIG, which comes up a lot. So key action statement 21, IVIG, and there's the dose for isoimmune hemolytic disease at or above escalation threshold, and you can repeat this in 24 hours. Other things to think about is rate of rise, response to phototherapy, and how quickly you can get your exchange. So sometimes if you can't get your exchange, then they would say, even though you're at exchange levels, to do your IVIG while you're waiting for exchange. There is some association with NEC in some observational studies. There's more data in the technical report where they look at 11 studies. There's unclear evidence on the effectiveness to prevent an exchange transfusion. The most recent study did not demonstrate the reduced risk for exchange transfusion. Overall, there is weak evidence that it may decrease the need for exchange transfusions. That's not the strongest statement. And as you look at their citations, there's a large degree of heterogeneity in the studies. But these studies actually, and as you read the studies, it sounds a little better than what the recommendation. They do say that.
Brandon, you're muted. We cannot hear you.
Sorry, my computer just turned off, so I had to jump on one of the other computers in this office here. I apologize.
Oh, okay, good.
Let me just pull it back up. I'm almost done, but I can go through quickly.
Just continue. Okay, thank you.
Okay, let me share my screen. Okay. Can you hear me, Dr. Kamat? You okay? You guys can hear me and see me?
I can see you, hear you, but I cannot see your slides yet.
Okay, hang on. Let's see. Share screen. You can see it now?
I see your slide first, the IVIG slide, yes.
Okay, and this is where I was when I don't know when I got cut off because I looked up and my screen was completely black.
I think this is the time you were off, yeah.
Okay, so as I was talking about IVIG, there is a IVIG is relatively safe, but there is a lot of heterogeneity, and interestingly, as you look at the studies, while they were very cautious in the guideline, the studies are a little better for it. And I will tell you, practically speaking, as a NICU fellow, I have never actually done an exchange transfusion, but I have done IVIG multiple times. So it is something that we regularly do, especially we use it in those isoimmune cases. But there is some controversy regarding it. So, and I think the reason for that is, as you talk about your exchange transfusions, this is key action statement number 22. Urgent exchange transfusions should be performed if there's any signs of acute bilirubin encephalopathy, like we talked about. And urgent exchange transfusion if the bili is above the threshold. If during preparation, I think this is important because I've seen this actually happen a number of times, both here and in residency. If during preparation the bili falls below the exchange levels, then you can defer. You do not need to continue to do your exchange transfusion. And basically, you put the donor blood in, you take it out. These are our exchange transfusion thresholds. Again, there's two different charts. There is no difference between 38, 39, and 40 weeks for the exchange transfusions. And I again put this in the 2004 versus the 2022, but you do see the increase. So it went from 25 in our 40 weekers all the way to 27, and these levels just did increase a little bit as we go through these thresholds. So what is a double volume exchange transfusion? 2 times the infant blood volume, so 2 times 80 mLs per kilo, which is going to replace 85% of the blood volume. Use the freshest blood possible. You draw usually from a UAC or an arterial line and infuse from the UVC. So as you're taking blood out, you're putting it in. And as I mentioned, I have not had the opportunity to do so yet in fellowship, but having heard from many people who have done it is very exciting for the first 2 times you draw out. And then after that, for the many, many other draws, it becomes a very tedious task. They do recommend giving 10 mLs per kilo of FFP halfway and some calcium for each 100 mLs of blood exchange. These are the complications. This is why I think IVIG is gaining more favor, because the complications, microemboli, arrhythmias, volume overload, cardiac arrest, because of the problems with the potassium, electrolyte abnormalities, metabolic acidosis, respiratory alkalosis, thrombocytopenia, infection or transfusion reaction. So, so again, double volume exchange transfusion is something that is going more and more. There's less and less of these naturally occurring, but it does still occur. And I will tell you, in places like the Nigeria where I was, they were doing 1 exchange transfusion per day. And Tina Schlusser had the same comment. And as I tried to figure out why this is, I think a couple of reasons. 1, because of the G6PD, but 2, and most importantly, because the inability to test mothers for antibodies and inability to test those mothers, so they didn't know which kids, and their inability to draw the labs quickly. So hospital policies and procedures, there's a comment on this key action statement number 25, and this is the last of our key action statement. We have made it through our lengthy tour with a slight bump. Is all parents should receive written and verbal jaundice education prior to discharge with appropriate follow-up appointments. To the pediatrician, there should be the TCB or the bilirubin, the DAT, who's going to see them. Hospitals should establish clear protocols of when and how to check bilirubin. And this is important. I think I just finished the QR project specifically about the nursing, empowering the nurses, but nursing protocols with standing orders should be established for physical assessments of jaundice, including the first 24 hours. And they actually go on to suggest things like saying if the nurse sees jaundice, that there should be a standing protocol where they can draw the bili in the first 24 hours. And all facilities should have appropriate phototherapy devices and mechanisms for transport. And I made it to the end, and I'm sorry I had to rush to the end. Again, I apologize that my computer went black in the middle of it. Hopefully that didn't affect my presentation, but I'll take any questions or comments that you may have now.
Thank you, Dr. Hadfield, for that update on hyperbilirubinemia AAP's 2022 guidelines. There's a comment in the chat box. These connectors findings are obvious neurologic findings and gross findings on imaging with very high bilirubin levels. This leaves out the huge question of less obvious neurological and undetectable imaging findings at lower levels. So high levels, you see these findings, but what happens at low levels? And then it is not separation from mother, it is separation from the mother, father, and other important family members.
Perfect. So I will address the first comment first. You are exactly correct. So while we can say that the connectors and the obvious connectors is at very high levels, what happens at those lower levels? And so there has been a lot of long-term follow-up studies, which I didn't comment on, and they did. And so in that one study of 500,000, it was only a retrospective chart review, so we can't say that they looked at all fine motor, but basically they did not see any noted abnormalities, so minor abnormalities. So I can't say definitively that at these lower levels that where there may not be some long-term effects, but they have not consistently has not been shown in the literature. And then the second question, Dr. Kamat, I think was about separation. Yes, I think that I agree. It is very important to think about that with bilirubin that you are separating. And I did just write mother, and I write because of the ability to breastfeed, but I think that the family bonding is just as important for father and for all the other people, and I 100% agree with you.
Thank you, Brandon. Dr. Seidner has a question. Dr. Seidner.
Thanks. Very nice presentation, Brandon. One correction, though, can you go back to your slide where you gave the example of bilirubin versus albumin?
Yes, sure. Hang on, it's going to take me a second, but I'll go there. Okay. This one or the one before?
The one before.
Sure. Go ahead. Oh, I got to pull it up. I think you're going to talk about this one, right?
Right. So your underline is backwards. So it's a bilirubin of 15 and an albumin of 1.5 is the same toxicity as a bilirubin of 30 and an albumin of 3.
Thank you. Thank you. I really appreciate that typo correction because obviously, yes, that would be, yes.
But I wouldn't want anyone to think that a bilirubin of 15 and an albumin of 3 is toxic.
Thank you. Thank you, Dr. Seidner. I really appreciate that.
There's a question in the chat box from Dr. Perlman. Was there no recommendation for ABR after severe hyperbili?
There was not a discussion about ABR after severe hyperbili in this guideline. However, they did say that this guideline, if it wasn't mentioned, doesn't necessarily supplant anything that was previously there. So the sweeping guideline couldn't cover all of the issues, and so they didn't specifically comment on that. But you are correct that one of the findings is sensorineural hearing loss in these kids. And so typically when the kids come to the NICU, they will get an ABR. Yeah.
Any other questions or comments for Dr. Hadfield? Dr. Petrashak, Dr. Manlik, Dr. Ellis, they all like your presentation. Very helpful in general pediatrics. So Dr. Hernandez, what did the experts cite as the benefit of extrapolation by gestational age over the 2004 grouping guidelines?
So what did they, I'm sorry, the question is, what did they cite as evidence?
As a benefit of extrapolation by gestational age over the 2004 grouping guidelines.
So I think that there was some discussion. I think that what Dr. Hernandez is getting at, which I think is an important piece, is that it complicates it a little bit more. So now you have a different curve for every single gestational age, especially with that risk of predictors being so low. But I think that the important thing that they point out here is that by extrapolating it by age, they can probably less kids will get phototherapy that maybe didn't need it. And so that would be I think that's why that they did it, but they didn't specifically have a large comment on that piece. But I think that the difference where 35 and 37 weeks are quite different in their risk factor. I think that's why they did it that way.
Thank you, Dr. Hadfield. Any other questions or comments? We still have a little time left. I don't see any. Thank you, Dr. Hadfield, for updating us on 2022 AAP guidelines on hyperbilirubinemia management. Thank you all for attending this morning's grand round. I'm going to close this grand rounds. Have a wonderful Friday and wonderful long weekend. We don't have to work on Monday for those who don't have inpatient responsibilities. Thank you all.